speaker who's returned, Emma Brown. She's an ICU reg from Northern Health, and she'll be talking about pharmacology, not just related to neuromuscular blockades, but related to sedatives and analgesics. I'm sure it'll be a very intriguing talk for everyone. Thank you. Next slide, please. So highlight for tonight's event, kind of the same outline as all of our other events where we've got our speaker. We're aiming to save the last 10 to 15 minutes for any questions if you have them. Feel free if you'd like to submit a question during the chat, or if Emma invites you to tune in and chime in and ask just live. Otherwise, we'll be using Slido as a link for you to send through your questions and for us to address at the end. There's the link. So make sure you get it. And over to Tom. Thank you.
Hello, everyone. I'm the sponsorship officer for PVACCS, and I'm very pleased to announce our recent affiliation with 𝗀𝗂𝗂𝗀𝗂𝗋𝗃, who is a financial advisory firm. They specialize in health professionals and providing both financial and taxation advice. So if you're interested, definitely check them out. The link should be on our website, or you can just Google 𝗀𝗂𝗂𝗀𝗂𝗀𝗂𝗀𝗂𝗀𝗂. Thank you.
So we'll introduce our speaker properly. So we've got Emma tonight, who's again kindly volunteered her time. She's from Northern Hospital. She has she's partway through her ICU training and brings a great deal of experience. Pretty keen to hear her talk. You might be familiar with her from one of our earlier talks last year, so it's great to have her back. Thank you very much, Emma.
Thank you, Matt, and the PVACCS team. I'm just going to share my screen. All right, can you guys see my slides there?
Yeah.
Yeah, excellent. So yeah, I was invited to talk about sedatives, analgesics, and neuromuscular blockers, and I know we've got a bit of a range of experience in the audience today, from medical students up to junior doctors. So the information I'm going to present is going to be sort of clinically relevant, focusing on comparative pharmacology between different drugs. And sort of the idea is to give you a bit of an idea and start to think about how you might choose between using different agents in your clinical practice. Just a disclaimer slide. I'm not an expert in this, obviously. I'm not a clinical pharmacologist. The only training I have is my medical degree and my clinical practice. And so this talk is based on my personal study for my intensive care practice and my experience as a registrar. As a result of that, this advice should not be used as a sole basis of your clinical decision-making. So please keep that in mind, and you must ensure you're always adequately supervised if you are going to be using these drugs in your clinical practice. If you're not sure about how to use these drugs or whether it's appropriate in the setting that you're in, always ask for senior advice or supervision. Just a brief outline of the talk today. We've got a lot to get through, so I'm going to move through things pretty quickly. If you do have any questions, feel free to pop them in the chat or the Slido, or just interrupt me if you want to ask something relevant as we go. That's totally fine. Otherwise, there will be a little bit of time for questions at the end as well. I'm going to start by just outlining some general pharmacology concepts. Not going to spend too much time on that, but then we're going to move into the clinical uses of sedatives, analgesics, and neuromuscular blocking drugs. That's what MNBD stands for. Where and why these agents are used, what's the goal when we're using these agents, and what are the precautions that we need to be thinking about. And then we're going to go through a brief comparative pharmacology overview of sedatives, analgesics, neuromuscular blocking drugs. And at the end, just some brief case examples where I'm going to ask you guys to suggest what drugs, based on the information you've heard, you might be choosing for that particular patient. So starting off, just some general pharmacology concepts. We're only going through these just to give you some introductory information about how we think about drugs and what pharmacology information we need to know about drugs when we're deciding which drugs to use. So this sort of stuff is what you're going to be needing to learn if you're thinking about sitting primary exams for intensive care or anesthesia. Some of you might have covered it in your medical degree or in previous pharmacology studies, but for me, this was all pretty new when I started studying for my ICU primary. So pharmaceutics is the first element of pharmacology, and essentially that is how the drug comes. And some of the things that we need to think about when we're thinking about pharmaceutics is the chemical makeup of the drug, the production, how is the drug produced, the preparation, which is essentially how it comes when you receive the drug. So is it in a glass ampule? What's mixed in that ampule? If it's in a pre-made bag, like a potassium chloride bag, what's in that bag? How big is it? What's the concentration? What's the pH? And then administration information. So what is the dosing? What are the routes of administration and all of that? The next element of general pharmacology concepts is pharmacokinetics. So this is what the body does to the drug. So you put a drug into a person, and then the body obviously distributes, metabolizes, and excretes that drug. So that's what pharmacokinetics is, or the pharmacology study of how the body handles a drug. Some of the key parameters we talk about when we're talking about pharmacokinetics is absorption from the route of administration into the bloodstream, and then distribution to the sites of action of the drug, metabolism, usually by organs or enzymes in the body, and excretion, or how the drug leaves the body. Other key concepts include things like extraction ratio, clearance, elimination, half-life, and compartment models. But we're not going to get into all of that stuff today because that can be some quite complex stuff. But those are the sort of phrases you're thinking about when you're thinking about pharmacokinetics. And then pharmacodynamics is what the drug does to the body. So we put a drug into a patient because we want it to have some effect. So what effect is the drug going to have when it's in the patient? And this is really focusing on the effects and the mechanism by which drugs act. Some more key concepts under the pharmacodynamics heading include things like drug receptor interactions, so how the drug interacts with the receptors in the body, affinity between the drug and receptor, efficacy of the drug, potency of the drug, whether it's an agonist or an antagonist, and then concepts like tolerance and tachyphylaxis that sometimes occur with certain drugs. And then finally, when we're thinking about pharmacology, we should also keep in mind that a lot of these general pharmacology concepts and the basic understanding of physiology is for a healthy, normal, physiological person. But of course, our patients are not that. Our patients have diseases, they're at the extremes of age, and they're taking other medications for which there may be drug interactions. So it's important that we think about the effects of these different elements in our patient on how the body either handles the drug or how the drug interacts with the patient's body and what it does to the patient. So those elements will all affect the pharmacology of how drugs work. Okay, now I want to move on to talking about where we're going to be using these types of drugs around the hospital. So obviously the first and most common place for using sedatives, analgesics, neuromuscular blocking drugs is going to be in anesthesia. Anesthesia is defined as the loss of sensation, but there are lots of different elements to anesthesia, and they include things like a general anesthetic or a reversible state of unconsciousness that patients might have to undergo major surgery, regional anesthesia, which is really blockade of nerve transmission, and that includes things like neuraxial anesthesia, like epidurals and spinals, and nerve blocks, which might be used in order to facilitate a procedure, but might also be used to provide pain relief, for example, in the case of a patient with rib fractures. And then there's procedural sedation, which is undertaken very commonly in the anesthetic department, but also, as we'll see, around other parts of the hospital. Procedural sedation, we'll get into a definition of it in a little bit, but it's a very broad range of practices. And so it's actually, I think, one of the hardest elements of using sedatives, analgesics, in clinical practice is this concept of procedural sedation and how much is enough and how much is too much when you're trying to enable a patient to go through a procedure without doing a general anesthetic. And that's for procedures like scopes, toes, plastics procedures are often done under procedural sedation. The next place is going to be the intensive care unit. Now, obviously, in the intensive care unit, we're still intubating some patients. So some of the value use of these drugs is going to be in the induction in order to facilitate intubation. And the difference between that and the anesthetic environment is that often, or almost always in ICU, it's an emergent or semi-emergent intubation that we're undertaking, not an elective procedure. Sedation obviously occurs in the intensive care unit, and it's very different to the type of sedation that you're using in anesthesia, which is usually a very short period of time. Whereas in ICU, we're talking about anywhere from a day to many weeks of sedation. And then we also do procedural sedation in the intensive care unit for procedures like those that are done in anesthesia, but that we're doing at the bedside in ICU. So things like TOEs, bedside scopes, tracheostomies. The emergency department is the other major area where you'd be using these medications. And again, it's quite similar to what we do in ICU, but over a shorter period of time. So they're still going to be doing inductions for intubation, usually in the hyperacute or even arrested patient. They might be doing a bit more regional anesthesia than what we do in intensive care. So they're doing things like beer block, ring block for procedures or suturing. And then procedural sedation, for example, for joint relocations after a dislocation. And then it's worth being aware, particularly if you're starting to work on a Met Call team or as a resident or registrar in the hospital, that there are other places around the hospital where people might be undergoing various degrees of sedation for other procedures. So that might be in radiology, if they're having an interventional radiology procedure. It might be in the cath lab. It might be in ECT down in the psychiatric unit, or it might be epidurals on the labour ward. Thinking about the goals of use is really important to working out what types of drugs are used and why they're used in a particular setting. So I want to spend a little bit of time talking about this for the different types of patients we're talking about. So first, focusing on the surgical patient. Now, the surgical patient may be elective or emergency. They may be undergoing major or minor surgery. And as we just mentioned, they might be undergoing various types of anesthesia. So it could be general, regional, or procedural sedation. They're generally managed with a definitive airway, particularly if they're undergoing general anesthesia. And there's different phases to general anesthesia that require different drugs to be used. So things like induction, again, in order to insert an endotracheal tube or an LMA, maintenance of anesthesia during the procedure, and then this phase called emergence from anesthesia, which is also a really important element. Thinking about the objectives of using these medications in this setting, I like to split it into a few different things. So there's what the patient needs to get out of the use of these drugs, there's what the physiology needs to get out of it, and then there's what the surgeon requires. And all of these things is what the anaesthetist in this circumstance is thinking about when they're choosing which agents are the right agents for this particular circumstance. So in terms of the patient, what's really important is providing an acceptable experience of surgery. So obviously a patient doesn't come to the operating room expecting it's going to be a fantastic time. They know they're having an operation, and that might involve a little bit of pain. It might involve some discomfort. It's a whole new experience usually for them, and it can be quite scary. But it's really important that when we're thinking about what drugs we use, we're thinking about how to make the experience better for the patient. And in particular, patients who are particularly anxious or scared at the beginning of an operation, that might feed into what drugs you're choosing to use. The other thing for the patient, obviously, is minimizing their pain. So trying to make sure that during the operation and after the operation, they have adequate analgesia. And then, of course, avoiding awareness. Most patients are most scared about being aware or remembering something from an operation. So it's really important that we choose the right drugs to provide hypnosis and amnesia of that operation. Physiologically, our goal is to maintain normal physiology, particularly in the patient who's an elective surgical patient, where they've come in with very normal physiology. We want them to leave again with normal physiology and ideally maintain normal physiology throughout the operation. However, we also need to establish an airway at the beginning of the operation, and that requires a pretty significant depth of anesthesia. And then we want them to also undergo safe recovery back to their normal physiology post-operatively. So back to breathing on their own, back to maintaining their own airway with normal blood pressure and all of that. And then the objectives of the surgeon really is that they want a patient who's not in pain and who's not moving during the operation, so they can do their best work and get the operation done. Moving on now from the surgical patient to the patient who's undergoing procedural sedation. So as we mentioned, this could be anywhere around the hospital in anesthesia, intensive care, the emergency department, or even those other places like radiology or the cath lab. Now, this is the definition I found for procedural sedation, which really most of the time is very difficult to define because it's such a range of practice. But this is from International Committee for the Advancement of Procedural Sedation. And they've said that the practice of procedural sedation is the administration of one or more pharmacological agents to facilitate a diagnostic or therapeutic procedure while targeting a state during which airway patency, spontaneous respiration, protective airway reflexes, and hemodynamic stability are preserved, whilst also alleviating pain and anxiety. So you can see here already, this is very different to the patient undergoing particularly major surgery, where you actually want to blunt spontaneous respiration and their airway reflexes and take over their airway for them. So when you're thinking about what drugs you're going to be using in this patient versus the patient who's having induction for general anesthesia, you've got totally different goals that you're trying to achieve. And you need to keep that in mind when you're choosing what drugs and how much you're going to give. Again, splitting this into the objectives for the patient physiology and the proceduralist, the patient, again, wants to be comfortable and have their pain well controlled, and also wants any anxiety around the procedure to be taken away if possible. Obviously, this patient's potentially going to be aware of some of what's going on during the procedure. So that can be quite anxiety-inducing for patients. Often they'll ask for a general anesthetic because they'd rather not know what's happening. So it's really important that we treat that for the patient so that they can tolerate the procedure comfortably. Physiologically, again, we're trying to maintain normal physiology, but in particular, as I said, in this circumstance, we're trying to maintain normal airway and breathing reflexes. And we want to avoid excessive or over sedation that's going to put our airway at risk or is going to result in the patient having a prolonged recovery time. In terms of what the procedural needs, they just want to be able to safely complete their procedure without too much interference from the patient because of anxiety or pain. And then moving on to thinking about the ICU patient, which is a very different patient cohort to the ones we've talked about already. Generally, the ICU patient is in ICU because of single or multi-organ critical illness. And when we're thinking about the sedatives and analgesics we're using, we're talking about much more prolonged use generally than for the surgical or procedural sedation patient. Usually these patients, if they require sedation, are being managed with a definitive airway. So in ICU, we're thinking about induction initially in order to achieve a definitive airway, and then prolonged sedation in the intensive care unit. And you can see this little schema on the side here, which demonstrates all of the various things that might be happening to an ICU patient at any one time. Thinking about the objectives again, patient physiology, and then thinking about a couple of other elements that are relevant to intensive care sedation, which are the therapeutic use of sedatives, and then also managing side effects. So when we talk about the patient, we know that patients who've been in intensive care units for prolonged periods of time, particularly on a ventilator, tend to develop PTSD. So what we really want to do is try to ensure the patient is as comfortable as possible, try to enable them to tolerate the various devices and procedures that are being done to them, and ensure if they are going to have a major procedure like a tracheostomy or a TOE during their time in intensive care, that we provide adequate procedural sedation for that. Physiologically, usually these patients have multi-organ or systemic illness, and so normal physiology may not ever have been present in these patients, but it's important for us to try to reduce the effect that our sedative drugs are going to have on whatever physiology is going on for that patient. So we really want to reduce the side effects of sedative drugs that might impair the patient's ability to recover from their illness. Thinking about therapeutic uses is a different sort of way of thinking about how sedatives and neuromuscular blockers are used in the intensive care unit. So sometimes we're using these drugs to achieve a particular therapeutic aim, as opposed to purely to provide sedation and paralysis. And some examples of that would be to facilitate particular therapies. So often in the intensive care unit, patients who are on a ventilator, if they're not adequately sedated, they might be interacting with or very desynchronous with their ventilator, which can worsen their oxygenation, worsen their ventilation, and require a lot of energy from the patient to try and breathe at a different rate to what the ventilator is doing. So often we will use deeper sedation and paralysis to try to control that so that we can take over ventilation, manage it for them, particularly during that critically ill period where they might be very hypoxic or difficult to ventilate. Another example would be in patients who have high intracranial pressures or who are having seizures and require burst suppression, using particular sedative drugs and neuromuscular blockers to try to reduce intracranial pressure or to treat seizures. Is another therapeutic way that we use sedation in ICU. And then because we're using these drugs over a much more prolonged period of time than in other settings, we do have to think about managing the side effects and cumulative effects of these agents. So in particular, concerns like propofol infusion syndrome, which doesn't generally occur in the very acute setting of sort of a general anesthetic, but can occur after patients have been on prolonged infusions of propofol. We have to keep an eye out for that. We have to be concerned about potential hemodynamic instability from sedation. So patients sedated for prolonged periods of time who may already be hypotensive from their illness could also have that worsened by the sedation that we're using. And then the cumulative effects of sedatives. So for example, opioid infusions. Over time, the opioid can accumulate in their tissues. And then when we go to turn off the sedation and try and wake the patient up, we find it has a very long duration of effect until the patient starts to clear all of that accumulated drug and starts to wake up from their sedation. So moving now into an overview of sedatives, or sometimes called hypnotics. So sedatives or hypnotics can be basically defined as agents that induce loss of consciousness. And they come under different forms, which I've outlined here for you. So inhalational, which we're not going to get into in a lot of detail today, because they're largely just used in anesthesia. But inhalational sedatives include drugs like the ethers or volatile anesthetics, which you might be familiar with, sevoflurane, desflurane, isoflurane. And then the oxides like nitrous oxide, which has specific uses. Then there's the intravenous induction agents. And when we talk about induction agents, we're talking about drugs that are typically used to induce a state of anesthesia. In order to qualify as an induction agent, a drug really needs to have some sort of predictable effect, such that specific dosing can be recommended in order to induce anesthesia. And they need to be short-acting, so that if you give a bolus dose to induce anesthesia, you know that after a certain amount of time, preferably within a space of minutes, the effect will have worn off, so that if you're having any trouble managing the airway in that initial induction, you know the drugs are going to wear off in a short period of time. Other intravenous sedatives don't really come under this heading of induction agents, and that's because generally they don't have that predictable effect. So exact dosing can't really be recommended, or they might be longer acting, like drugs like the benzodiazepines. We'll get into a little bit more detail about some of these intravenous sedatives in a minute. I've put in brackets there thiopentone and etomidate, because these generally aren't really used these days as induction agents. You may occasionally see them, but in my 8.5 years of practice, I haven't really seen these used at all as induction agents, though they may have other uses. So getting into some comparative pharmacology now of these agents. Initially, I'll just use an example of one of the gases, so sevoflurane. So in terms of mechanism of action, we're talking about a drug that is an agonist at the GABA receptor, an agonist at the glycine receptor, and an antagonist at the NMDA receptor. Sevoflurane has certain benefits to its use, or the anesthetic gases in general, and the biggest benefit really is that you don't need IV cannula in order to administer this sedative. And in particular, that makes them useful for use in young children for whom establishing IV access is quite challenging, and often they need to be induced before IV access is established. I've split up the other benefits into pharmacokinetics, pharmacodynamics, and therapeutic effects. So talking about the pharmacokinetic benefits of using the inhaled sedatives, they do have rapid uptake and washout and are minimally metabolized, and they're cleared by exhalation of the gas. So they're very quick to up titrate and down titrate in clinical practice. In terms of dynamics, they do depress the airway reflexes, and they have available monitoring for the depth of anesthesia using the MAC monitoring system, which we won't get into the details of, but it means that there's this objective way of monitoring how deep the anesthetic is based on how much of the inhalational anesthetic you're providing to the patient. And then they also have therapeutic uses, for example, in bronchodilation, say an asthma patient. Sometimes induction with sevoflurane will actually help the asthma itself, in addition to inducing anesthesia by providing some bronchodilation. But there are limitations to the use of these, and the main one is that they're only available really in the operating theatres. They can only be delivered through the anaesthetic machine, and generally anaesthetists are the only ones who are really comfortable with using these drugs. So they're not generally used around the rest of the hospital. They do have significant side effects as well, and in particular, post-op nausea and vomiting is a major one that tends to make people lean away from using inhalational anesthetics, particularly in patients who've had issues with nausea and vomiting before. They also can result in malignant hypothermia, cause hypotension and cardiovascular depression, respiratory depression, and emergence delirium. And then you'll hear anaesthetists talk a lot about the environmental impact of the inhaled anaesthetic agents, and that's one of the reasons why we are moving continuously away from using these drugs in clinical practice. Oh, the lights went off. You guys can still see me. Looking now at propofol as another example of an induction agent. So propofol is a GABA positive allosteric modulator. So it acts essentially as an agonist at the GABA receptor, and it has a lot of benefits, and that's why it's widely used in clinical practice. So in particular, it's cheap and widely available. There won't be anywhere where critical care can be provided in the hospital where propofol won't be available. In terms of its kinetics, it's a rapid onset and short duration drug, so perfect as an induction agent. And even during prolonged administration as an infusion, the context-sensitive half-time, which is essentially how long the half-time extends as you run an infusion for a patient, is not excessively prolonged. So even if the patient's been on propofol for a number of days, when you turn it off, the half-time is not going to be that much longer than it would have been if you just gave a bolus dose to a patient. In terms of dynamics, it does depress the airway reflexes and blunts the compensatory heart rate response to things like laryngoscopy. So it's useful, therefore, as an induction agent. And therapeutically, it has anti-epileptic and antiemetic effects. However, it has some limitations, and that it requires hepatic and extrahepatic metabolism to be cleared. And it is pretty significantly hypotension inducing. So you give most patients a bolus of propofol, their blood pressure is going to fall. And that's going to be particularly an issue in patients who have brittle physiology or who are already hypotensive. It can be sore to inject, and as I mentioned before, propofol infusion syndrome, particularly in children, can be a concern. And very few patients will have an excitatory reaction to propofol. Ketamine is the other major induction agent, and it's a non-competitive NMDA receptor antagonist, so operating via a different mechanism to propofol. Ketamine has a lot of benefits, and you'll see its use increasing over the course of your clinical practice. Year on year, ketamine is becoming a lot more commonly used. Its benefits include that it can be given IM as well as IV, which is excellent if you're trying to sedate a patient who either doesn't have IV access or is agitated. In terms of its dynamics, it provides a dissociative anesthesia. So patients might still have their eyes open and be looking at you, but they will essentially be dissociated and unaware. It also has some analgesic properties and what we call this indirect sympathomimetic effect, or what you might hear people describe as it being cardiovascularly stable. What that means is that in the patient who's hypotensive, this can be a really good option because it might actually give them a little bit more blood pressure and a little bit more heart rate. It preserves airway reflexes and ventilation as well. So it's really good as well as a drug to use when you're pre-oxygenating a patient. You want them to keep breathing on their own to maintain their airway reflexes before you do the full induction, but you want them to tolerate something like NIV or CPAP for pre-oxygenation, and they're a little bit ratty or agitated. Ketamine's a fantastic drug for that. In terms of therapeutic effects, it's also a bronchodilator, so it's sometimes used in asthma and in particular in induction of asthmatic patients. In terms of its limitations, unlike some of the other drugs, it does require it to be drawn up and made up into a bigger syringe than what's in the initial vial that you get. So it's a little bit of an extra step in preparing the drug for administration. It's also cleared hepatically, and it has a slower onset than other induction agents. So propofol, very rapid onset after a bolus, probably within 30 seconds. Whereas ketamine, it's more than one arm brain circulation time. So you're thinking about more like 90 seconds to 2 minutes for the full effect. It can cause an increase in cerebral blood flow and cerebral metabolic rate of oxygen consumption, which is just the brain's oxygen consumption. Which is a negative if you're talking about a patient who's already got intracranial hemorrhage or high intracranial pressures, and you don't want to increase their cerebral blood flow or oxygen usage. It can cause salivation as well, and just like it's cardiovascularly stable and can help in the hypotensive patient, in the patients who's already hypertensive or tachycardic, it can exacerbate that. And so sometimes it's not the best agent to use in those patients. Some of the other sedatives that are not induction agents, but are used in other clinical practice, midazolam, and then I'll talk about dexmedetomidine. Midazolam is a fantastic drug for things like pre-medication for the anxious patient who's going in for a general anesthetic. It's also great for anxiolysis in procedural sedation. And it has amnesic properties. So if you're providing procedural sedation for something like a toe DCR, and you don't want the patient to remember the DCR element, midazolam is a really good agent for that. It also works at the GABA receptor. It comes in multiple formulations, and it preserves, it's again cardiovascularly stable, so it preserves the compensatory heart rate. It's also reversible, which is one of the few drugs in the sedative group that is reversible, and you can use flumazenil to reverse the effect. So if you've accidentally over-sedated a patient and they're not breathing enough, or you're worried about their airway, you can give them some flumazenil and reverse the effects. It also has therapeutic effects. As we know, it's an anti-epileptic, and it can treat withdrawal syndromes. It does have active metabolites though, and undergoes hepatic metabolism, and is moderately long acting with a longer half-life than some of the other agents. And it can cause significant respiratory depression. Dexmedetomidine, some of you may or may not have heard of. It's really only used in the intensive care setting, and it's not really used as a bolus dose sedative anywhere. It's only used as an infusion. Occasionally we see it used in theatres by some anaesthetists, but generally it's really just used in the intensive care unit, and it's really approved for peri-extubation sedation. The reason for that is because it provides what is called arousable and cooperative sedation and anxiolysis, amnesia, and a degree of analgesia, whilst preserving respiratory function. So dexmedetomidine we can run as an infusion and keep it going even as we extubate a patient at the end of their ICU ventilatory period, because they will be calm but alert and have preserved respiratory function. So it's really more used for the agitated patient in intensive care units rather than as a sedative drug or an induction agent. It can cause significant bradycardia and asystolic arrests. I've seen that happen, so it does need to be used with caution. We're going to move on now to talking about analgesic drugs, and again go through some comparative pharmacology of analgesics. If anyone has any questions, please feel free to interrupt me, but I will leave some space, like I said, for some questions at the end. So when I think about analgesics, this is how I split it up in my mind. I talk about systemic analgesics and regional analgesics. We're not going to get into regional anesthesia in this talk. It's just too big of a topic. But essentially, regional anesthesia uses local anesthetics, opioids, and adjuncts, either as a single application or via a catheter for infusion and bolusing. And there's various types of regional anesthesia, such as neuraxial, peripheral nerve or plexus blocks, facial blocks, and then wound or joint injections. But we're going to be focusing on systemic analgesics, which I split into the simple or non-opioid analgesics, the opioids, and then the adjuncts, which are really ketamine and the central alpha-2 agonists, and then other pain-relieving agents. So, for example, specific drugs for neuropathic pain, like the tricyclic antidepressants and gabapentinoids, and skeletal muscle relaxants like baclofen and benzodiazepines. Looking at the simple analgesics, so non-steroidals and paracetamol, all of us, I imagine, have taken these drugs ourselves before. So we know they're really well tolerated, they're widely available, they come in many formulations. And these days you can actually get both of them as IV drugs as well. They obviously both COX inhibiting drugs, and under the non-steroidals, there's a lot of different agents that have various specificity for the different COX receptors. And then paracetamol, we know, has some other effects on the serotonergic, cannabinoid, and bradykinin systems. They both have a lot of benefits and both provide antipyretic and anti-inflammatory effect as well. But the limitations for both are important to know about and to think about when you're using these drugs in your clinical practice. They're not completely benign agents. And in particular, for the non-steroidals, you need to be concerned if the patient has renal impairment, if they have GI diseases, particularly ulcer disease, if they're at risk of thrombotic or bleeding complications, or if they have asthma or COPD, then the non-steroidals can cause bronchospasm. For paracetamol, as we all know, paracetamol toxicity from excessive use or overdose can be very serious, can even cause liver failure and death. So that hepatotoxicity is really important to be aware of. And if you suspect a patient has been taking too much paracetamol, it's really important to check their liver function and their paracetamol level. Moving on to the opioids, and I'm just going to focus on 3 different opioids to give you sort of a flavor of how we think about the different opioids, but there's obviously a lot of opioids. And in fact, if I go back to my previous slide, the opioids can be subclassified into the naturally occurring ones, such as morphine, the semi-synthetic ones, such as oxycodone and buprenorphine, and then the synthetic ones like fentanyl and all of its other ones like L-fentanyl, remifentanil, etc. You can also subclassify the opioids in a different way, thinking about their mechanism of action at the opioid receptors. So are they pure agonists at the receptors? Do they have mixed agonist-antagonist activity like buprenorphine? Or are they antagonists? And really those are not opioids. That's really naloxone that we're talking about as an antagonist at the opioid receptors. Getting back into the opioids, so morphine has a lot of benefits, and you'll find it's a bit polarizing as a drug in clinical use. Obviously, we know in ward-based use, it's commonly used in palliative care or relieving symptoms of MI or breathing difficulties. Sorry, just readjusting myself. But in terms of using it in sort of the more anesthesia or sedation space, it's not that commonly used. Certain intensive care units will use morphine more frequently than others, but certainly at my intensive care unit, it's not used a lot. And in anesthesia, you won't see it used very often at all. Some of the benefits of morphine are that it has a longer duration than some of the other opioid analgesics, and that provides more effective pain relief for patients who have ongoing pain. It is a low potency opioid, and what that means is that if your drug is less potent, you need to give a bigger dose to achieve the same effect. And by giving a bigger dose, you essentially are providing more drug to the patient at a single time. And so you can see, again, better effect from that drug. However, there are limitations to the use of morphine. That is why it's not used so commonly, and that is that it has active metabolites, meaning that while those metabolites are still present, you'll still have some ongoing opioid action. It's renally excreted, meaning it's not great in patients who have renal impairment. And this histamine release, which I never thought was really a thing until I saw a patient have 5 or 10 milligrams of IV morphine as part of an induction of anesthesia by an older anaesthetist who liked using morphine. And the patient's entire arm swelled up with welts from the histamine release associated with that IV injection. So it is a concern. It can cause not only local but also global histamine release and an anaphylactoid reaction. So that is actually one of the reasons why morphine is used so little in anesthesia. It does come with a greater risk of respiratory depression and OSA exacerbation because of this higher dose, longer duration of action that it has. Fentanyl, commonly used, but again, polarizing. You'll find some people really love fentanyl, some people really dislike fentanyl. It has benefits. It doesn't have it has inactive metabolites, meaning that you're not going to get that prolonged effect from the ongoing effect of the metabolites, and it's better in renal failure because it's not as reliant on renal clearance to get the effect to go away. It just relies on its metabolism. And then once you've got inactive metabolites floating around, it doesn't matter how long they take to clear. But it does have limitations because it's a highly potent opioid, so much more potent than morphine. You actually use it in very small doses to achieve a clinical effect. And what that means is that it's not quite as effective, and it's certainly less long-acting than morphine or oxycodone. Clinically, what I find is that you'll give a dose of fentanyl to a patient. It might relieve their pain for a reasonably short period of time, but then their pain will come back again, and they will experience not particularly good pain relief. Whereas in my clinical practice, I find if you're using morphine or oxycodone, particularly for an acutely painful pathology like renal calculi or postoperatively, that you get smoother, more prolonged and more effective pain relief with some of the other drugs like morphine and oxycodone. But that's my personal experience, and you'll find every clinician you speak to has a different view of these drugs. The other limitation for fentanyl is that it's highly lipid soluble and distributes into lipid compartments. And so if you're running an infusion of fentanyl over a prolonged period of time, it will accumulate in those lipid compartments and then take a long time to redistribute and be excreted once you turn that infusion off, resulting in a very long context-sensitive half-time. Nonetheless, we still use fentanyl as the analgesic in our combined sedative analgesia regimes in ICU for prolonged periods of time for our ICU patients. Almost exclusively, we're using fentanyl for that because of concerns about the prolonged effects of morphine and the greater risk of respiratory depression, etc. So even though fentanyl has a lot of drawbacks, it's used extremely commonly, particularly in the intensive care and in anesthetic settings. Oxycodone has a lot of benefits, very similar to morphine in terms of its action and benefits, but obviously also comes in an oral combination with naloxone, which reduces GI side effects for patients who are taking prolonged oral oxycodone. The limitations really, again, similar for morphine, and oxycodone is used quite commonly instead of morphine in anesthesia and post-anesthetic pain relief because it's not associated with as much histamine release and it's better tolerated by patients. Some of the analgesic adjuncts, so ketamine, a non-competitive NMDA receptor antagonist. We already talked about this in terms of its sedative properties, but in terms of its analgesic properties, again, some of those same benefits that we saw when it's used as a sedative. It preserves respiratory function, unlike the opioids. It provides dissociative analgesia and anesthesia rather than just purely sedating the central nervous system. And it's safe to use as an infusion on the wards for your postoperative patients. Some of its limitations are, though, in those patients, as we mentioned, who are hypertensive or tachycardic, and it can have a complication of causing hallucinations and vivid dreams. For most patients, that's a pleasant experience. It's not necessarily scary or terrible, but you do have to warn patients, because if it happens unexpectedly, they will think they're going crazy, and they won't want to continue the ketamine. But if you warn them in advance, we're running this ketamine infusion for your pain after your big operation, and you might experience some visual hallucinations or very vivid dreams, that's fine. It's not an issue, and we can continue the drug as long as it's not concerning you. The patient might say, no, it's really scaring me and I don't want to continue. But they might say, oh, actually, I'm just seeing some horses galloping across the sky in front of me and it's fine. Clonidine, very similar to dexmedetomidine, but clonidine tends to be used more commonly for its analgesic properties, and dexmedetomidine more commonly for its sedative properties. Again, a central pretty sure it's an alpha-1 adrenergic receptor agonist. No, maybe it is an alpha-2. Yeah, it is an alpha-2. Its benefits, so in addition to analgesia, it provides anxiolysis and reduces heart rate and blood pressure. But on the flip side, the limitations are that it can cause bradycardia and hypotension, and it can cause significant sedation. And then if you're using clonidine as an analgesic and then you stop it suddenly, they can get rebound hypertension and tachycardia. All right, moving on to the neuromuscular blocking drugs. So this is my little diagram of the neuromuscular junction. Hopefully you guys can kind of see it and make sense of it. But I'm going to talk you through the neuromuscular junction, and then we're going to look at some of the drugs that affect it. So in terms of what is the neuromuscular junction, it's essentially where the alpha motor neuron terminal bouton, which is, I'm not sure if you can see my indicator, but is this round bit in the middle here.
Yeah, we can't see your mouse.
Yeah,
sorry.
That's all right. It's where it synapses with the motor end plate of the skeletal muscle cell at the bottom of the diagram there. In terms of the structure of the neuromuscular junction, so the alpha motor neuron terminal, that round blob at the top there, is full of these little vesicles of acetylcholine. And the ones at the back are in the stationary store. The ones in the middle are the reserve pool of vesicles of acetylcholine, and the ones right down the front near the membrane are the active zone of vesicles of acetylcholine, the ones that are ready to be released as soon as they're told to. Also on the alpha motor neuron terminal bouton, you'll find voltage-gated calcium channels, reuptake receptors for the metabolites of acetylcholine to be reuptaken into the alpha motor neuron. What we call presynaptic acetylcholine receptors, as well as lots of mitochondria to make acetyl-CoA, and lots of choline derived from the diet or the liver, so that the acetyl-CoA and the choline can make acetylcholine. The synthesis occurs in the axoplasm of the alpha motor neuron. And then in between the alpha motor neuron and the motor end plate is what you call the synaptic cleft. The motor end plate on the bottom side of that diagram is where you've got these peaks and troughs or invaginations. And on the peaks, you'll find the nicotinic acetylcholine receptors. And in the troughs, you'll find the acetylcholinesterase, or the enzyme that breaks down acetylcholine. And then off to the side there, on the right side, you'll see there's some extra nicotinic acetylcholine receptors. And they're what we call extrajunctional acetylcholine receptors that are proliferated outside of the neuromuscular junction, and that can occur with certain pathologies such as burns. Thinking about the function of the neuromuscular junction, so what happens is you get an action potential coming down through the alpha motor neuron, and it reaches this terminal bouton or the nerve terminal. It causes depolarization of that nerve terminal, and that causes these voltage-gated calcium channels on the right side there to open and allow calcium entry. It's that calcium entry that then mobilizes the vesicles of acetylcholine to release their acetylcholine into the synaptic cleft. The acetylcholine then interacts with the nicotinic acetylcholine receptors on the motor end plate side of the junction. And then by interacting with those, they open and allow sodium entry into the motor end plate. That changes the voltage there and generates a excitatory postsynaptic, what's the second? EPSE, excitatory postsynaptic, like a depolarization. If it reaches a certain threshold, then it actually causes depolarization of the whole motor nerve end plate. And then that action potential is propagated across the sarcolemma and down the T tubules in order to depolarize the whole muscle cell. And as we know from our excitation-contraction coupling, once you depolarize the cell, the calcium channels on the motor cell open, calcium comes into the cell, and contraction can go ahead and occur. Now, that's the straightforward action of the neuromuscular junction, but some of that acetylcholine that's released into the synaptic cleft will also go back to the presynaptic acetylcholine receptors and stimulate those. And those cause sodium influx into the terminal buton, which then mobilizes the reserve pool of vesicles to move forward into the active zone so that more acetylcholine can be released. The acetylcholine in the synaptic cleft is then broken down by the acetylcholinesterase into choline and acetic acid, and then those elements are reuptaken into the terminal buton to be reused and to recreate acetylcholine for the next time. All right, so now when we think about drugs that are acting as neuromuscular blockers, we have some idea in our minds of how the neuromuscular junction works. Again, separating out the different neuromuscular blocking drugs into categories, we've got our depolarizing ones, which are agonists at the nicotinic acetylcholine receptor. And our main drug under that category is succinylcholine. Then you've got your non-depolarizing ones, which are competitive antagonists at the nicotinic acetylcholine receptor. They bind and block the nicotinic acetylcholine receptor, whereas the depolarizing ones bind and open the nicotinic acetylcholine receptor, hence why they're called depolarizing, because they do result in depolarization of that motor end plate. The non-depolarizing ones are split into the aminosteroids and the benzyl isoquinoline. And then you've got different classes as well, such as dantrolene, which is used as a treatment for malignant hypothermia, but we're not going to get into that. Reversal agents for your neuromuscular blocking drugs include the indirect muscarinic agonists, otherwise known as acetylcholinesterase inhibitors. So they block the action of the acetylcholinesterase enzyme, preventing the breakdown of acetylcholine in the synaptic cleft, meaning that there's more acetylcholine available to compete with the neuromuscular blocking drugs to try to get the nicotinic acetylcholine receptors to be working. Those are drugs like neostigmine, used very commonly in the anesthetic department. And then there's cyclodextrins like sugammadex, which reverse particular neuromuscular blocking drugs by forming a tight complex with the drug itself and removing it from the site of action. Looking at some of our neuromuscular blocking drugs in more detail, so succinylcholine. This is our depolarizing one, as I explained. It has a number of benefits. It's very short acting, will wear off within 15 or 20 minutes. And it has a very fast onset because it only requires about 20% receptor occupancy to see effect. So even with reasonably small doses, as long as you're getting that 20% receptor occupancy, you're going to see neuromuscular blockade from this drug. There's a visual cue in the form of fasciculations to know that the drug is now working. So you give the drug, you wait to see the fasciculations of all of those neuromuscular junctions depolarizing, and then the fasciculations will go away, and that's when you know the drug is working. And it undergoes organ-independent elimination by plasma cholinesterases, so it doesn't rely on liver or kidney function. However, on the flip side, the short-acting nature of it means that it's a bit limited if you're worried that the patient might require quite prolonged management of their airway, that it's going to wear off quite quickly, and you might be midway through trying to get a front of neck access because you couldn't get oral access to the airway, and then it will wear off and the patient might start moving. So you have to keep that in mind. It has a number of significant side effects. I've blocked them under 3 major, 3 minor, and 3 pressures, but essentially the major ones are anaphylaxis, succinylcholine apnea, meaning prolonged effect, and malignant hypothermia. Some of the minor ones include hyperkalemia, which is a relative contraindication to using succinylcholine because it will pretty reliably cause the potassium to go up. Other contraindications include myopathies or neuromuscular junction disorders, or patients with burns who have a lot of extrajunctional nicotinic acetylcholine receptors. Rocuronium is an example of one of the non-depolarizing muscle relaxants, and it has a lot of benefits over succinylcholine in that it's longer acting and it's reversible with sugammadex. It also has less likelihood of causing anaphylaxis and has far fewer contraindications or side effects generally. It does have a slower onset because it requires greater than 75% receptor occupancy to be effective. It has some limitations though. You don't get that visual cue that it's working, so you just have to do a time-based assessment once you give a dose about 60 seconds or so before you would expect the full effect. And it is organ-dependent elimination being excreted in the bile and urine. And then 𝗖𝗓-𝗪𝗓, another example of a neuromuscular blocking drug, again has some benefits over succinylcholine in being longer acting and less anaphylaxis and contraindications. It still has organ-independent elimination by Hoffman elimination, so it's good again in the patient with renal or liver failure, but it does have that slower onset again. Limitations, again, no visual cue that it's working, and its metabolism can be affected by pH and temperature. It also has a potentially toxic metabolite that can cause seizures. Thinking about potentiating the effect of non-depolarizing muscle relaxant activity. So at the neuromuscular junction, there's a number of different things that might increase the effect of your neuromuscular blocking drugs. They include anything that reduces presynaptic acetylcholine. So aminoglycoside antibiotics and magnesium block these 𝗲𝗂𝗂𝗀𝗃𝗀𝗀 channels, reducing calcium entry and therefore reducing acetylcholine release at the neuromuscular junction. Similarly, calcium channel blockers or �υ𝗂𝗃𝗀𝗀𝗃𝗀 will impair the effect of that voltage-gated calcium channel. Altering drug receptor interactions is another way of potentiating non-depolarizing muscle relaxant activities. So diseases like myasthenia gravis, which has autoantibodies to acetylcholine receptors, meaning that there's fewer available acetylcholine receptors and your drug's likely to attach to all of the available acetylcholine receptors and have therefore a greater effect. And also acidosis, which increases the affinity of neuromuscular blocking drugs for the acetylcholine receptor. Anything that alters the postsynaptic membrane might affect the effect of non-depolarizing muscle relaxants. So, for example, hypokalemia, which hyperpolarizes the motor end plate, or volatile anesthetics, which stabilize the motor end plate, will reduce the effect of acetylcholine at the acetylcholine receptors and therefore potentiate the effect of neuromuscular blockade. And postsynaptic sodium channel blockade will also affect it. So certain drugs like local anesthetics, lithium and phenytoin. And finally, anything that reduces the metabolism of your neuromuscular blocking drugs is going to mean that they have a longer or greater effect. And that's things like renal failure and liver failure for those that are metabolized by those organs, or hypothermia, which slows down enzyme processes, particularly that Hoffman elimination for 𝗖𝗓-𝗪𝗓.
Emma, I might just flag with you that 7:30.
Yeah. I'll just spend a minute on this slide and then I'll go through a couple of examples and get you guys to tell me what drugs you might use. So when you're choosing which drugs to use, everything that we've talked about obviously is important in thinking about the pharmacology of the drugs, but there are a couple of other considerations, and those are what environment you're in, what equipment you have available, particularly to manage the airway, what people you have around, particularly, again, people who can manage an airway, and specific things about the patient, their past history and their current state. And then you have to think about what is the goal you're trying to achieve. Do you need the patient to be unconscious? Do you need to provide analgesia? Do they need to be paralyzed? Now, I want you guys to, I'm not sure how we're going to do this, but I want you guys to maybe just jump in or put up your hand and say just examples of some drugs you would or wouldn't use in a particular case. So our first case is a healthy young patient who attends for elective general surgery under a general anesthetic. Based on what we've talked about, what drugs might you be thinking about pulling out for their induction of anesthesia?
Propofol.
Yep. What else are you going to use?
Some sort of analgesia.
Yep, some sort of analgesia, absolutely. And anything else? This patient's having major abdominal surgery.
Or paralysis.
Absolutely, you're going to want to use some paralysis. So yeah, and that's pretty much the standard cocktail for most patients undergoing their general anesthetic induction for elective anesthesia, a major surgery. What about if they're very anxious about having their first anesthetic? What might you add in?
With us?
Yeah, absolutely. So what you might be doing for this really anxious patient is you get in the drip in the pre-anesthetic bay, and they're saying they're really quite worried, and they're asking you lots of questions. They're like, oh, I don't know about this mask for oxygen. I'm pretty scared about having my operation. I just pre-medicate them with a little bit of midazolam. And then for your induction, you're thinking about a big dose of propofol, a big dose of fentanyl, and then a big dose of a neuromuscular blocking drug. You want to get control of that airway and get the tube in with as little fuss as possible. And this patient's got normal physiology to begin with, and they'll tolerate these drugs well. What about if they have diabetes and they've got gastroparesis? Now, we didn't really talk about this, so it's all right if no one knows what the answer to this one is. What other considerations might there be? That's right, I'll jump in. So we didn't really talk about RSI, but rapid sequence induction is really achieving induction of anesthesia very quickly in patients where you're worried about them aspirating gastric contents, so either in the unfasted patient or the patient who has some issue with gastric emptying. In those circumstances, succinylcholine is traditionally used in the RSI because of that very rapid onset, visible cue that it's effective, so you can apply cricoid pressure knowing that when you give the neuromuscular blocker, and then you know exactly when it's working, and you want to secure that airway as quickly as possible to prevent aspiration. What about in the young, healthy toddler who comes in for surgery? We talked about this right at the beginning. What sort of induction agent might you be using?
I might use a volatile anesthetic.
That's right. You'd be thinking about using your volatile anesthetics. They don't have a drip yet. It's going to be very traumatic trying to get a drip into a toddler who's pretty difficult to cannulate. So an inhalational or gas induction initially. Once the child is reasonably asleep, that's when you're going to be putting in your IV access, and then you can follow up with further induction agents like propofol and some muscle relaxant in order to secure the airway. Now, looking at a different type of patient, what about your shocked cardiology patient being intubated in the ICU? They've come from the cath lab, they've had their cath for their STEMI, but they've got cardiogenic shock, they're hypotensive. What type of agents are you thinking you might want to use to intubate this patient?
Would you need a mix of opioids and a sedative? Because if you just relied on propofol, you'd risk making them more hypotensive.
That's exactly right, yeah. Propofol is probably not the right drug for this patient at all, and you definitely want to be trying to achieve sedation and analgesia without excessively compromising their hemodynamic state. So one of the really common drug combinations in ICU patients, particularly shocked ICU patients, is ketamine, fentanyl, and rocuronium. A reasonable dose of ketamine to get that sedation and induction of anesthesia, a decent dose of fentanyl to blunt their sympathetic response to laryngoscopy, and then a big dose of rocuronium because this patient might already have renal failure. You don't want to give them hyperkalemia or some other side effect from succinylcholine, but a big dose of rock will achieve really good muscle relaxation in a short period of time, and you can get the tube in quickly. What about your elderly lady who's come in for a gastroscopy for iron deficiency anemia? Now we're talking more about the procedural sedation side of things.
Again, because their hemodynamics are going to be impaired. So sorry, they're going to have a reduced cardiac output, presumably, because she's elderly. So you wouldn't want to use, or you could still use propofol, but you'd probably pair it with something to reduce the amount of propofol you'd give. Or you could use, well, I've not really seen it done, but I guess you could use inhaled, like a volatile.
Yeah. Did you say earlier that midazolam is it'll help maintain blood pressure?
Yeah, for some reason, midazolam not used very much in scopes. What the anaesthetists will tend to use is a slow, low dosing of propofol. So they'll essentially get a syringe of propofol and they'll give little boluses at a time just to achieve enough sedation, plus or minus a bit of an opiate, in order for the patient to tolerate the scope without overdoing it. They don't need to induce anesthesia. They don't need to get an airway into this patient. They just want them sedate enough that they're able to tolerate the procedure well. So it's just about titrating the propofol to effect, whilst, as you say, Hannah, trying to avoid that blood pressure effect that you get from big doses of propofol. And then you've got your patient being intubated with respiratory failure. They've got renal failure and fatty liver disease as well. What sort of drugs might you be thinking about using?
Is the respiratory failure hinting at that you probably wouldn't use a volatile?
Not necessarily. If this patient went to theatre, they may very well use a volatile. But what I was thinking about, and really we're talking, this patient's probably going to be in the outside of theatre context. This patient's probably okay to use propofol if their hemodynamics are okay. You'd want a decent dose of fentanyl, and then you can think about using ketamine for your pre-oxygenation. This patient might need NIV for pre-oxygenation, and so in order to tolerate that, some ketamine might be helpful. And you can consider those neuromuscular blockers that aren't cleared by the kidneys or the liver, but in reality, we actually just still use rocuronium for most of these patients. That's it. All right, quick questions, and then I'll go off to work.
That was really good. Thank you, Emma.
Yeah, thank you very much. So Rachel, would you mind sharing the Slido, please?
Yeah, we've just got 2 questions in there, but I have to go through both of them. Got my screen. Oh, never mind. Okay.
Do I need to stop sharing my screen?
Yes, please. Thank you.
I'll just very briefly, that's my resources. If anybody wants to take a photo of that, those particular 4 textbooks I found really useful in studying for pharmacology. All right, I'm going to stop sharing. In ICU, people often have a fentanyl and propofol infusion for sedation, but why would you use 2 when you could just give propofol? So the main reason why we use both in the intensive care setting is to try and get the sort of additive effect of the 2. So essentially, if you wanted to use just propofol for sedation of these patients, you would be finding that you'd have to be using 2 or 3 times as much as we currently use in order to achieve the effect that you want, particularly for blunting their respiratory effort, and for keeping them comfortable. You would really be having to use very high doses of propofol, and the more propofol you use, the higher the risk they're going to develop propofol infusion syndrome. So we use this combination not only because a lot of the things we do in ICU are uncomfortable, so it's good to provide some pain relief for the patient, but also because the addition of an opioid reduces how much propofol we have to use to sedate that patient, and particularly helps with respiratory depression if we're trying to manage their ventilation. And the second question, can you give midazolam as an infusion, or do you just give it as a 1 milligram boluses for sedation? Yeah, so you can use it as an infusion, but I wouldn't recommend it for procedural sedation. For sedation, I would just be giving small boluses titrated to effect. Even for older people, 0.5 milligrams is often enough for most small procedures. You might be giving 0.5 or 1 milligrams every 5 to 10 minutes to achieve procedural sedation. But in intensive care, we will use midazolam infusions as part of our sedation protocols. And similarly, they'll use them in palliative care and that sort of thing, but I wouldn't be using it for procedural sedation. And like you say, it has a long half-life. It can take a long time to wear off. So that kind of puts us off using it too much as a prolonged infusion.
That was really good. Thank you so much, Emma.
Oh, good. If anyone has any other questions, you can always email me, elbrown with an E on the end, 3@gmail.com.
Well, good. Thank you so much.
Cool. Thanks, everybody.
Have a good night at work.
Thank you.
See ya.
Thank you, Emma. Have a good shift.
Bye.